Coming to Dobutamine stress echo, it is an important test in assessing of cardiac viability. Before going to the Dobutamine stress echo, we should know what is the categorization of wall motion. So categorization of wall motion is defined as either this is labeled as hypokinesia, akinesia, dyskinesia, and scar. Hypokinesia is defined as preservation of some degree of thickening and inward motion of endocardium during systole but less than normal. So hypokinesia means there is the name itself denotes that is decreased movement as preservation of some degree of thickening and inward motion of the endocardium. So whenever the heart contracts, whenever during systole heart contract, the muscle gets thickened, and as well as there is inward motion of the myocardium. So if some degree of that is preserved, it is called that. So it has been arbitrarily defined as if it is less than 5 millimeters of endocardial excursion, that is endocardium is moving inside by less than 5 millimeters. Less than 5 millimeters, if it is there, then it is called as hypokinesia. Akinesis is defined as absence of systolic myocardial thickening and endocardial excursion. So there will be no thickening during systole. There should be thickening of the myocardium. So there is no thickening of the myocardium, and also there is no endocardial excursion. That is, endocardium is not coming inside, or movements is not there in akinesia. Dyskinesia is most extreme form of wall motion abnormality and is defined as systolic thinning. So generally during systole, the muscle gets thickening, but if there is systolic thinning, and during systole, if there is outward motion, normally there is inward motion of the myocardium. If there is outward motion, if it occurs, is called as dyskinesia. A left ventricular segment that is thin and highly echogenic suggests the presence of scar. So for Dobutamine stress echo, the protocol is patient is prepared for standard stress testing. Intravenous access is obtained. You take digital images record. So baseline images you will take. Then Dobutamine infusion is started at a dose of 5 micrograms per kg per minute. So Dobutamine is an inotropic agent. So if there is any tissue is viable and all, the contraction of that part will increase. So the infusion rate is then increased every 3 minutes. You will check, and infusion rate is increased from 5 micrograms per kg to 10, 20, 30, and 40. Low dose images are recorded either 5 or 10 micrograms per kg per minute. Atropine can be given during the mid and high dose stages to augment the heart rate response. It is like a stress test, so you have to increase the heart rate also to check like further responses. So coming to the responses, so at rest, if the tissue was normal at rest, that means the thickening was normal, the movement was normal during systole, and if the movement is becoming hyperkinetic, that means normal. So Dobutamine is increasing the contractility of that, so that's why it is causing hyperkinesia. So at rest, if it is normal, and during stress, if it is becoming hypokinetic or akinesia, that is decreased movement or complete absence of movement, if occurred, that means interpretation is ischemia. At rest, if it was akinetic, and also after Dobutamine, also if there is no movement coming to that means the tissue is already infarct or dead or necrosed. At rest, if it was hypokinetic, it becomes akinetic or dyskinetic, that means the tissue is again ischemic or infarction. Or if that rest, if it was hypokinetic or akinetic, and with the stress, that is Dobutamine, if it is becoming normal, it means the tissue is viable. So you can see there is biphasic response to Dobutamine stress. There is you can see at low dose Dobutamine and with peak dose Dobutamine, there is reduced systolic thickening at rest, increment with low dose, and deterioration at peak dose in the lateral wall. But the lateral wall, you can see that first low dose there is increased movement is there, but with higher dose again there is completely akinesia of this part. What are the endpoints and reasons to terminate the Dobutamine infusion during stress test? So you're doing a stress testing now. So what are the endpoints when you should stop the infusion? Is that so? If the patient has reached the target heart rate of 85% with no significant changes, then it means that the patient has reached the endpoint, and you should stop the Dobutamine infusion. If the patient during the Dobutamine develops a significant angina or classical angina, you should stop the test. That itself denotes that the test is positive. Recognition of a new wall motion abnormality. So there was a normal movement before and after the Dobutamine. If you see in any part of the echo or myocardium, if there is new wall motion abnormality, or if there is decrease in systolic blood pressure of more than 20 from baseline, and patient develops any arrhythmias, atrial fibrillation or non-sustained VT, or limited side effects or symptoms, then also it is called as you should stop the test. ECG evidence of ischemia is less reliable during Dobutamine infusion than it is during exercise testing. Normal exercise testing, generally the ECG changes are very much important, but neither ST segment depression or nor elevations during dobutamine infusion is significant because dobutamine itself is known to cause ST segment depression or ST elevations cause. So any ST segment depression or elevation occurring during the procedure in the absence of any wall motion abnormality is not a indication to stop the test. Safety of dobutamine, because of the short half-life of dobutamine, if indivisible ischemia can be readily reversed, you can actually reverse it through termination of the infusion. If you stop the infusion, the ischemia can be reversed. In severe cases or when the ischemic manifestation persists, a short-acting intravenous beta blocker can be given. You can give a short-acting intravenous beta blocker can be given, such as metoprolol or esmolol is effective. The most common side effect associated with dobutamine is minor arrhythmias such as premature ventricular contraction and atrial arrhythmias. Non-sustained ventricular tachycardia occurs in approximately 3% of patients. What are the contraindications for dobutamine stress echo? There is no absolute contraindication. Unstable patients are those with uncompensated heart failure for unstable angina. Dobutamine echo has been safely performed in patients with recent MI, extensive left ventricular dysfunction, abdominal aortic aneurysm as well.